Our final speaker for the morning is Nora Volkow, who's director of the National Institute on Drug Abuse, and she'll talk about FDG, Contribution to Our Understanding of Addiction.
Thanks very much. Good morning, and I want to congratulate Joanna Fowler and Brookhaven National Laboratory for this wonderful honor, very deserved honor. And we've seen already examples of how dramatically FDG has changed the practice of medicine, and it will continue to do so. But I do want to convey on another perspective that has not been discussed very much, which is what really FDG did for the neuroscience field. I am trained as a psychiatrist, and actually one of the things that I had been taught through medical school and then through training in psychiatry was that the way that you made a diagnosis for a patient with a psychiatric or a neurological disease was by observing symptoms. But you really didn't have a grasp or an understanding of why were the symptoms present. And so the only way that you could actually try to link pathology with behavioral symptoms was, unfortunately, to wait until the patient died, and then through post-mortem analysis, that would allow you to identify which areas of the brain had been affected and to what extent that explained the symptoms. To a certain extent, that had been valuable in neurology because neurology deals with things such as epilepsy, stroke, a tumor, where you can very clearly localize where the pathology is, and that led to an understanding of, well, if you have a stroke on the left side of the brain, you're much more likely to have impairments with language because that's the main predominant area. So by being able to map where the pathology was and what the symptoms were, there was this mapping of what the brain may be doing. That was a very different story in psychiatric diseases, because you could have a patient that was fully blown psychotic, hallucinating, delusional, and the patient would die, and you would look at the brain, and maybe there was some ventricular atrophy, some cortical atrophy, but it didn't tell you anything whatsoever of where the pathology was. And so the extent to which, for the first time, we have this capacity to look inside the human brain and see how the human brain works was completely transformative, completely and absolutely transformative. And it was the FDG that made this possible. And I would put forth the concept that it was FDG that then really led to the blossoming of all of the other technologies that have emerged since then that are actually based on that, what Lou Sokolov was saying, the basic understanding of the need of energy when neuronal cells are activated. And that, of course, has led to new technologies like MRI that derive from this very basic understanding of how, when the human brain gets activated on a given area, you can see an increase in glucose metabolism. So this was utterly transformative in the whole area of clinical neurosciences. And obviously it also, as you have seen very elegantly by the work of Moni de Leon and some of the presentations of Abbas Alavi, some of the cases, it also has transformed neurological diseases. And it will continue to do so. In the case of Alzheimer's disease, in the case of epilepsy, in the case of Parkinson's disease, PET technologies now are reimbursed. Currently, there are no indications in psychiatry for reimbursement of PET technology, for the use of PET. On the other hand, it is an extraordinarily powerful tool for investigating multiple diseases. And my task is specifically where does FDG rely in all of these developments. I would say FDG is central to all of this development because, and Lou said it, and I think that pertained to the last question, we were looking at blood flow, but blood flow is actually delivering oxygen and glucose to the areas where the cells are located. Glucose is being taken up by the cell that these other technologies are trying to look at. And that's why it's so much more specific. And that's why it allows us, at the end of the day, to determine are the neurons taking or not energy. And so when we're having these discussions of amyloids or tau, at the end of the day, we want to know how that pathology ultimately influences the function of those cells. So if neurons are not functioning, they are not going to be consuming glucose, whether there's amyloid or not. The bottom line is the neuron functioning or not. So and Joanna said, Nora, can you speak 15 or 20 minutes? And I said, okay, I'll speak 15 or 20 minutes. I want to highlight. So how do I do it? and we've done a huge amount of work. So I needed to highlight 2 examples within our work where FDG has really been instrumental in transforming the way we look at a disorder and the way that we may treat it. So I'm taking 2 stories, and both of them are unfinished studies. And I actually like the idea of unfinished stories, because when you go into a research and it ends there, it basically usually means that it was not very complex. When you go up into a story and it keeps on asking and asking questions, then you know that you basically are hitting a very rich mine. And so I selected two examples. And one of them is the investigation of using FDG to look at the effects of acute and chronic drugs of abuse. And Lou Sokolov had done a really remarkable work in preclinical animals showing that the administration of a wide variety of drugs that actually target the dopamine system, which is very important for drug abuse and reward, had profound effects on brain glucose metabolism. And these studies, because we haven't even gone there, FDG also has been widely utilized in experiments in laboratory animals to actually understand basic neurobiology and circuitry. But Lou Sokolov had shown that drugs that either are agonists or antagonists of the dopamine pathways through dopamine D2 or D1 receptors produce very specific changes in regional activity, which in turn allow you to understand, well, how does dopamine regulate those regions? So within that background of work, we started one of the first studies that we started doing was to understand how acute drug administration of something like alcohol or something like cocaine or something like marijuana would affect brain glucose metabolism. So this is one of the first studies. And again, to tell you how basically science surprises you, and this could have not been done with any other radiotracer or methodology. So we were interested in understanding how those acute alcohol administration affect brain glucose metabolism. And so we've been doing a series of studies. Actually, this is the one that was published in 2006. And what you're seeing there are 2 things. These are images at the level of the basal ganglia. This is at the cerebellum of normal control while they are sober. And this is the same subject tested on a different day after he or she has been given 0.25 grams per kilogram. 0.25 grams per kilogram of alcohol is a relatively low dose of alcohol that may be, I guess, more or less equivalent to a glass of wine. And what was very interesting was that a abrupt decrease in brain glucose metabolism with such a small amount of alcohol. Then we were doing an alcohol dose study. So I'm showing 2 doses, 0.25 and 0.5. So the subjects were tested on 3 different occasions, either 0.25 or 0.5, or other subjects were randomly assigned to 0.25 and 0.75. So I'm only showing you 0.25 and 0.5. So this is the placebo, and this is, again, a 0.5 grams per kilogram, which may mean 2 glasses of wine. And again, look how dramatically reduced brain glucose metabolism was in these subjects. And this was very intriguing for several perspectives. To start with, we had been, from the literature in the animal studies and from the literature actually from stimulation studies, we were able to see that if you activated one area of the brain, we could correlate that with behavior. And we could see that, for example, with studies where we had been giving stimulant drugs, and we could correlate, or we had been giving benzodiazepine drugs, and we could correlate specifically benzodiazepine decreases in glucose metabolism in the thalamus with subjective perception of sleepiness. But with these findings, what was extraordinarily intriguing was that you were observing these decreases in brain glucose metabolism, but we could not associate them with any of the behavioral effects of drug intoxication. So we were saying, well, what's going on? Now, this is the data. I showed you images for this particular study in which we are comparing the differences, percent change in glucose metabolism, absolute values of 0.25 milligram, that tiny dose, one glass, versus 3 glasses of wine. And you can see very, very robust decreases throughout the whole brain. And I'm putting here data that we had collected prior with the use of lorazepam, 30 micrograms per kilogram administered intravenously, which is actually quite a hefty dose of a benzodiazepine. And the patients become very, very sleepy. And I'm using it just to convey why we were very surprised by this finding, because this benzodiazepine drug, which actually was making subjects very, very sleepy, had much lower decreases in brain glucose metabolism than we were observing with alcohol. And as I say, in this case, the decreases specifically in the thalamus for the benzodiazepine were associated with sleepiness. So this was, to start with, did not completely make sense in terms of what we knew about it. Then we did a separate study in which we were actually designed to compare males and females. And again, this was another incredible surprise, because what we were observing was that the males show much more robust decreases in brain glucose metabolism than the females for the same amount of alcohol when corrected for their body mass index. Now, what was so this was interesting too, because of the following thing. As one would expect, if you look at the literature, if you give a certain amount of alcohol to a female, curiously, she's much more likely to get a higher level of intoxication than a male. And this has to do, in part, with the way that alcohol metabolism differs between males and females. So these females were much more intoxicated than these males, despite the fact that the decreases in brain glucose metabolism was much smaller. Now, the reason why we were at this point here, actually, and why we had, certainly obsessed and continued to think about this discrepancy between the effects on brain glucose metabolism and the intoxication and what it would mean, was we had done, and this was one of the first studies that when I came here, I was involved with on doing, giving alcohol to alcoholics and measuring brain glucose metabolism. And to our surprise, and my brain's surprise, the amount of glucose metabolism that was decreased by alcohol in alcoholics was double the amount of normal controls. Even though they were not intoxicated, they didn't feel the effects of alcohol, and at that time we were given 1 gram per kilogram, so healthy controls were very, very drunk. The alcoholics were not, but they had a massive decrease in brain glucose metabolism. So based on that, we proposed that, that we could not just explain this in terms of the decreases in brain glucose metabolism reflecting decreases in neuronal activity, which is the normal way that you would interpret it. But we said, could it be possible that during alcohol intoxication, you may, in fact, be utilizing an alternative energy source? And we published, we put that in 2006, and that generated it's interesting in the basic neuroscience literature, because traditionally it had been thought that the main source of energy for the brain is glucose. So researchers started to look at an alternative sources of energies, and at that time, recently after that, there was a paper published in PNAS by the group at Yale using magnetic resonance spectroscopy, showing that actually acetate was the preferred substrate for glial cells. So the problem, and they went on to discuss that the reason why normally we see very little acetate metabolism in the brain under normal conditions is because the plasma concentration of acetates are very low. But when you get intoxicated, the concentration of acetate in alcohol, because alcohol is metabolized to acetaldehyde and then to acetate, can go up to 1 millimolar. So those are concentrations that will be able to sustain a significant portion of the energy requirements of certainly glial cells, at least 30%. So after much going back and forth, we were able to get C11 acetate labeled here, and Sonny Kim, who's sitting someplace there, actually played a very important role in this endeavor, and to ask the question, can we use C11 acetate to actually determine if there is an increase in acetate metabolism during alcohol intoxication, and is the acetate metabolism higher in alcoholics than in controls? And we postulated that it would be higher in alcoholics than in controls because of that particular finding, where we showed that in alcoholics, alcohol decreased glucose metabolism in the brain at double the amount than in a normal control, suggesting that perhaps the chronic administration of alcohol and the continuous high levels of acetate may actually shift the preference and the enzymatic expression that will result in a higher consumption of acetate in alcoholics than in controls. So we did a study, and the study was very interesting. Actually, it was complex. We just published it a couple of months ago. And this we have, we compare two groups of subjects. These are the occasional social drinkers. These are the heavy drinkers. And you see the increases in acetate during alcohol intoxication. This is the heavy drinkers. You see the increase in acetate uptake during alcohol intoxication. Overall, and these are values for frontal and cerebellum, so this is placebo, placebo, placebo normal, placebo alcohol. Intoxication normal, intoxication alcoholic. And you see that overall the alcoholics had higher levels than the controls, but that did not reach statistical significance. It was at 0.06, but it certainly was into a trend, suggesting indeed that our hypothesis was correct. And I just came back last week from the Society of Neuroscience, where I heard a presentation by the group at Yale, who had actually also been very interested on the particular possibility that acetate may be a source for energy utilization. And using spectroscopy, they reported that alcoholics show double the amount of acetate metabolism by the brain than controls, indicating that indeed the brain may shift its energy substrate under conditions, in this case, of a substance of abuse. Now, why is this significant, apart from the fact that it's actually one of the things that we're learning, that the brain may only be a little bit more promiscuous than what we thought with respect to what it selects for energy, and that indeed acetate can be an energy substrate for the brain. But what it is telling in my brain, and again, this is a story that has not been finished. We actually just published this, and the question is, what is driving these changes, and are they relevant? Well, they are relevant for the following thing, and let me see. This is, okay. I'm sorry, I thought this should have been in color. But two things, in terms of one of the most intriguing findings in the literature, and multiple studies have come on comparing alcoholics and controls, comparing cocaine abusers and controls, comparing cocaine abusers and alcoholics. And one of the things, and we've participated in all of these studies, is we've been doing them now for many, many years. One of the things that is striking is when you compare, and you cannot see this because it's in black and white, it's not very good, but what many investigators have been showing was if you study an alcoholic, say within 1 week of last use of alcohol, what is dramatic is how reduced brain glucose metabolism is in this individual, dramatically reduced. And the other thing that is very, very interesting is, and actually this that I think we may have been the only study as of now that has been published this, and this was an old study, 1992, is brain glucose metabolism in alcoholic recovers. And it recovers within 30 days. And so here you have the data for an alcoholic study during the first week of the last use of alcohol, and then you see the same patient after they have been detoxified for 30 days. And so you have the values for the whole brain, and you can see there is many of the subjects, except for these three overall, there is an increase in brain glucose metabolism. Now, at that time, we were actually figuring out and say, well, there is these decreases in brain glucose metabolism cannot signify that there is that there's neuronal loss and death, because if there was neuronal loss and death, then you could not get this type of recovery. And moreover, when you are treating alcoholics in whom there's no evidence of head trauma or improper nutrition, you can actually see a significant degree of cognitive recovery with detoxification. So my question in my brain right now is, could it be that this very significant decrease in a relatively short period of time on brain glucose metabolism, will it signify the fact that that is what's allowing the brain to recover back its step from favoring the utilization on acetate to be able to use FDG, glucose, as an energy source? Now, why is this important? This is important because clinically, what is it that you do with an alcoholic? So a heavy alcoholic goes into the clinic, and you actually, there are two fields. There's a field that opposes the use of any type of medication for the treatment of a drug-addicted person. So if you're an alcoholic and then up there, you're going to go cold turkey. And cold turkey is not very good for your brain because you can actually end up with very severe seizures. And there's actually a patient, if severe enough, can die from a very, very acute withdrawal. The other strategy is to give them benzodiazepine for 2 or 3 days. So my question based on this data, and I don't have an answer, is could it be that if we take these alcoholics who presumably their brain has been used to the use of acetate as an energy source, you are removing the acetate and they are going to go into energy deprivation. So why not give them a diet that is rich in acetate? So how do you do that? Ketone-rich diet. And those diets are completely innocuous, are used for the treatment of epilepsy. And so I had put that as a completely speculative thing on the paper that we wrote. And then I look at the literature, and lo and behold, there was a clinician that actually used a ketogenic diet in alcoholics and reported much, much better recovery. Now, this was many years ago, and he did it just sometimes we do things out of serendipity and randomness. But it does put forth the concept that a technology like this one can bring us focus into something that we have not been paying attention at all, which is that drugs of abuse directly influence the energetics of the brain apart from their effects on neuronal activity. And this is something that I think we're going to be hearing more and more, not just for the actions of drugs of abuse being able to influence energetics, but as I think it was Abbas or Moni, I don't recall which one of them said, that there is an increasing interest in the whole area of clinical neuroscience in recognizing that diseases, and it's not just Alzheimer's disease, it's also diseases like Parkinson's disease, it's also diseases like depression, may have a fundamental disruption of energetics. And so there's the recognition that if your mitochondria cannot produce the energy, that's going to lead to impairment in neuron function, but also very likely, and I haven't even touched that, impairment in function of glial cells. So the direction of this is actually now a clinical one to test if indeed taking alcoholics during detoxification and giving them a ketogenic diet can improve their outcomes. Now, the second example that I want to put forward is another one that is of also a long, long history, but one that has led to a really transformation on the way that we view the process of drug addiction in general as a disease of the brain. And this is a strategy that we've used at Brookhaven for many, many years, very successfully, which is to use FDG as a cornerstone that gives us information of neuronal function. Extraordinary important information just on baseline neuronal function. What is the status of the tissue? So we link it with other markers, in this case dopamine D2 receptors, so that we can ask the question if there is a change in the expression of these dopamine D2 receptors in the brain, how does that affect function? And we can do that by measuring both of them. We can then inquire the data and see if I have decreases in these proteins in the brain. How does that affect the function of the different areas of the brain? So this is a strategy, as I say, we've been using now for many, many years. Now, what our group, and now replicated by many other groups throughout the world and in many laboratory animal experiments, but Brookhaven National Laboratory was the first one to show that, was the fact that whether if you're a cocaine abuser, a methamphetamine abuser, an alcoholic, a heroin, more recently shown for smokers, nicotine smokers, you're much more likely to have low levels of dopamine D2 receptors in the human brain, in the striatum. And that was a molecular finding because you could actually, and this just shows two of our studies. These are patients that were hospitalized in which we measured dopamine D2 receptors using methyl spiroperidol, a high affinity ligand for the dopamine D2 receptor. And these are studies that were outpatient, cocaine abusers, measured with C11 raclopride, a ligand that has a lower affinity for the dopamine D2 receptors. Controls are in purple, cocaine abusers in green, and I'm portraying the model parameter that we use, in this case the ratio index versus the Vmax KD, the non-displaceable binding potential, as a function of age, because also, and we have shown this at Brookhaven National Laboratory, as we grow older, the expression of dopamine D2 receptors in the striatum goes down. But what we showed was, irrespective of those age effects, in these two groups of cocaine abusers, you can see that there is a decrease in the availability of these receptors. And as I say, this is not specific for cocaine addiction. We see it as a wide variety of the drug addictions. And this has been replicated left and right. It has also been replicated in laboratory animals where we can actually manipulate the levels of receptors. And by doing that, Peter Tanos was the first one to work that when he came here as a postdoc, was able to interfere with the compulsive administration of drugs. So we know they are very, very important. The question is how is it that one single protein, dopamine D2 receptors, can have such a profound effect in determining your vulnerability for compulsive administration of the drug, which is what we know that these low levels of dopamine D2 receptors are doing in your striatum. They are making you much more impulsive, and they are actually facilitating compulsive behaviors, repetitive behaviors that cannot be terminated. So in these subjects, we measure brain glucose metabolism. And to our surprise, and this was, again, something that now everybody says, of course, but at that time, nobody was paying any attention on what I'm going to show you. The whole field of drug addiction and preclinical and clinical was focused on the limbic brain, and the sense that people were addicted because the reward system got involved. And actually, there were all sorts of hypotheses about the limbic brain and the reward system being at the essence of drug addiction. So when we did the studies, and we did show decreases in D2 receptors in areas of reward system, but then when we did the studies with brain glucose metabolism, what I found was actually quite surprising. And I'm showing you data of individuals that have undergone withdrawal and detoxification. So, which is very different, as you may expect by now that you have been hearing us speak about FDG, if you study these patients immediately after cocaine withdrawal. But what emerged was that what differentiated, and again, consistently, not just cocaine abusers, alcoholics, there's also for marijuana abusers, a common abnormality is that they all, regardless of whether they had this high or very low global decreases in brain glucose metabolism, what we see in alcoholics, if you normalize for that whole brain glucose metabolism, even then you can see that they all have a decrease in the metabolic activity of the frontal cortex. And here, that is most pronounced in this area just on the top of your eyes, that is called the orbital frontal cortex, and in this area part on the anterior cingulate gyrus. And our first findings with these were in the 80s, and this was a very surprising because no one had considered that the frontal cortex was important for the process of addiction. Because the frontal cortex is involved with executive function, decision-making, judgment. And drug addiction was considered that it was a disease of the limbic brain. And these data here show that it actually, one of the consistent impairments was in these areas of the frontal cortex. So then we plotted up, and again, not knowing, I mean, we were in unexplored territories. It would have been elegant to say, I'm going to postulate that decreases in dopamine D2 receptors in striatum that I show you there are going to be associated with X, Y, and Z. We did not know. We actually had shown that there were decreases in the striatum in the dopamine D2 receptors, but we did not know how that was going to affect brain glucose metabolism. In fact, I predicted that it would be related to brain glucose metabolism in the striatum, but that was not where the correlations emerged. And in fact, when we sampled the whole brain, and what I'm just showing are the areas in here, field, orbital frontal cortex, prefrontal cortex, and cingulate gyrus, the areas where the correlations were significant after you, of course, account for the multiple comparisons. The striatum was not significant after we accounted for the multiple comparisons. And what we showed, and I'm showing, and we've replicated these cocaine abusers. We've had 2 studies on cocaine abusers, methamphetamine abusers, and we've also shown it in alcoholics. The lower the levels of dopamine D2 receptors, the lower the metabolic activity on the orbital frontal cortex and in the cingulate gyrus. The same thing in the methamphetamine abusers, the same thing in the alcoholics. Now, so this was transformative because it was shifting light into the frontal cortex as being crucially involved in drug addiction. Now you enter in PubMed, enter frontal cortex and addiction, and you'll emerge, numbers of papers are emerging. No one is questioning it, and that has led really to a great granularity in understanding how specific areas of the frontal cortex are involved in the pathology, in the neuropathology and addiction. And in fact, the MRI group here at Brookhaven National Laboratory, Rita Gosling, Nellie Klein, Dardo Tomasi, have played a very important role in helping delineate how the derangement on these frontal cortical areas, different frontal areas, are affecting the symptomatology. Clinically, at that time, that data didn't exist. But to me, what it was telling it is, I'm faced with data that in the orbital frontal cortex, nobody had paid much attention to that area, except that this was a time, again, it was in the 80s, where people were studying patients with different psychiatric diseases and localizing the abnormalities. And there was this really fascinating study in patients with obsessive-compulsive disorder that identified the orbital frontal cortex as the basis of the pathology. And so that's when to me, putting those two things together gave me, basically what is common between drug addiction and obsessive compulsive disorder. And what you have common of those two disorders is the compulsive quality of the behaviors. In one, the person washes and washes their hand, even though they know their hands are clean. In the other one, the person takes the drug again and again and again, even though they'll tell you the drug is no longer rewarding. So the understanding that disruption of this striatal dopamine circuit that regulates the orbital frontal cortex, that regulates the single-A gyros, is the mechanism by which, evidently, having low levels of dopamine D2 receptors in the striatum is making you vulnerable for compulsive behaviors. Without this area of the brain, without the orbital frontal cortex, without the single-A gyros, you cannot inhibit prepotent responses. And then more recently, we showed that actually in subjects, which again is another area that we haven't even touched at, but we can see the enormous value of brain glucose metabolism and FDG, as well as PET technology, is our understanding about how genetics and heredity may be influencing. And there were a couple of examples presented earlier. But this is a study in which we did exactly the same multiple tracer approach, where we measure dopamine D2 receptors, where we measure brain glucose metabolism, except that these are not individuals that are addicted. These are subjects who come from a family history of alcoholism. The father is an alcoholic, the sibling or the mother or the uncle is an alcoholic. And we then, using statistical parametric mapping, we actually then inquire where, not just pre-selecting regions, but throughout the whole brain, where do we see the associations? And again, in these individuals at risk, we're observing the same pattern. Low levels of dopamine D2 receptors are associated with low metabolism in these areas, whereas high levels are associated with normal levels of brain glucose metabolism. And we postulate that, in fact, the reason why these individuals, despite their genetic history of alcoholism, are not alcoholics is because their orbital frontal cortex, their single-A gyros, is perfectly functioning. Of course, if they start taking alcohol, D2 receptors will go down, and that whole balance will be lost. Then we have taken this and applied it, and Jin-Jack Wang has taken a lead on this whole effort to see, well, if we actually use the same methodology on another disease that is actually also characterized by compulsive patterns, by lack of control, do we observe the same thing? So in 2001, Jin-Jack and colleagues, we published a paper in which we show that there is a decrease in dopamine D2 receptors in the striatum. And then subsequently, we also show that this is associated with decreased metabolism in the orbital frontal cortex and in the single-A gyros, indicating that indeed a basic component on these syndromes of behavioral discontrol, whether it is drugs or food, relates to an impairment on the striatal regulation of frontal cortical areas that ultimately lead to the inability of the individual to inhibit these very strong prepotent responses, which of course has led to models of addiction that are much more complex, that indicate that drug addiction is not just a disease of the reward brain system, but that the prefrontal control circuitry are markedly impaired, and in parallel, there is a sensitization of memories that enhance the value of the reward associated with a drug, driving the behavior that cannot be inhibited because the prefrontal cortex, which normally controls, cannot stop it. And this, in turn, of course, is leading to new therapeutic interventions with approaches aimed to balance this disruption of several neuronal circuits that are affected by drugs. And the delineation of actually those circuits was possible because we have access to a measurement of brain glucose metabolism, which is the closest indicator of brain function. And I want to end my presentation with my colleagues. Actually, I named some of them, but of course I haven't named yet Joanna, which actually which has been central to bring that cohesiveness of our group together. And we have named many of the scientists involved, but as importantly and as crucial to what we do is the really remarkable technical assistance that we have had within the group, but also, I would also say, within Brookhaven National Laboratory. And I want to just state this work was possible because it was at Brookhaven National Laboratory And I don't think it is aleatory that these big advances that have generated on a relatively, if you take everything into consideration, a relatively short period of time since FDG was developed were possible because of the unique environment that Brookhaven National Laboratory has placed, which in my view is actually really highlights why it is important to have laboratories and spaces where science of very different modalities can occur, as opposed to very specialized centers. That this is what happens when you actually bring the opportunities that you come up with solutions that otherwise would have not been possible. Thanks very much.
Okay, we have time for a couple of questions. Go ahead.
So I just say, Nora, then that the reason the beta receptors are in the drug abuse, if we say one implement that is contained together, is because they're predisposed to the compulsive behaviors as a result of the beta receptors being lower. I mean, the part of it is also, the beta receptors are lower because of the chronic drug use.
We know that chronic drug use decreases expression of dopamine D2 receptors in the striatum. So we know, and in these subjects at risk for alcoholism, they didn't have low levels of dopamine D2 receptors when compared to controls. Actually, their levels were higher. So we know from studies in rats, in mice, in non-human primates, that repeated administration of chronic drugs of abuse leads to a downregulation of dopamine D2 receptors in striatum. I don't rule out the possibility that there are individuals that, because of genetics or stress exposure, may have lower levels of dopamine D2 receptors in the striatum, even though they've never been exposed to drugs. And we know that is the case, too. So we know that you can have both a situation where someone having low levels of dopamine D2 receptors in the striatum, that may put them at risk, then they take drugs, and that will further decrease it, as well as someone that may be perfectly normal, then starts to take drugs, and then that leads to the downregulation. Well, it's an interesting question, and you know, I hadn't thought about it in that respect, but it's actually intriguing because certainly acetate, for once, is one of the radiotracers used for cancer, and there's also last year, the past 2 years, have also started to show that acetate, C11 acetate, may be a very good marker too for assessing physiology of muscles. So, it has been used extensively for cardiac imaging. So now, normally, if we're not drinking, the amount of acetate in our blood is going to be very, very low. Alcoholics do very, very poorly in a wide variety of medical conditions, which is going to be another confound because alcohol is pro-inflammatory. So you have to start with vascular pathology, and that in turn will influence, for once, other conditions and diseases. But to the extent, I mean, I think it's a question is, so if you have someone that is drinking alcohol, how that ultimately influences the growth of cancer cells, I do not know. And it would be interesting to do that, for example, in a laboratory animal to see if you can detect differences in the rate of growth. But in humans, it's going to be extremely complex because of all of the confounds. It's a very intriguing question. Yes, indeed, and actually I was going to say, because they were saying cardiovascular disease accounts for a significant number of people's deaths, but in the world there are 5 million people that die every year from smoking-related diseases. 5 million, it's huge. Now, and addiction is unfortunately a stigmatized disease, and as a result of that, and is really not recognized as one of the responsibility of the healthcare system to address. And particularly in the, I shouldn't say this, but in our healthcare system, in Canada, for example, they have started to incentivize physicians such that if they can help their patients to stop smoking, they get a bonus. And I guess a shift towards understanding that interventions to basically help individuals stop smoking or prevent smoking will gain us an enormous amounts in dollars that are not going to go into the healthcare system because, of course, it's extremely costly. Now, will this happen or not? Well, that's my other hat, and where I'm trying to basically make this argument about why we need to develop treatments for drug addictions. And one of our priorities has been the development of treatments for smoking cessation. And we're, again, testing multiple targets. One of the areas which helped us enormously when we got the stimulus package was it allows us to invest really extensively to try to develop immunotherapies for drug addiction, which is something that we had started to fund before, but we were limited to a couple of investigators. So now we have multiple strategies to the developments of vaccines. The vaccine that has been most advanced, a nicotine vaccine, which actually has been given to humans, if you get vaccinated with a nicotine vaccine, you develop antibodies, and if you develop high enough titers of antibodies, then the antibodies will bind to nicotine, and nicotine cannot get into the brain. So you basically don't feel anything. The studies have shown that in those individuals that do get the titer of antibodies high enough, they stop smoking. They completely stop smoking. The problem and the challenging has been that most people that are vaccinated do not have the antibody response necessary. That is, the vaccines are not sufficiently antigenic. So we have a parallel trial with cocaine vaccines where we are seeing exactly the same thing. Only approximately 20% of patients have titers that are high enough to interfere with cocaine going into the brain. But again, we're funding researchers that are using extremely clever ways of trying to overcome the poor antigenicity of our current vaccines. At the same time, other researchers, and there was a presentation at the Society of Neuroscience last week, are also trying to determine, can I predict who's going to respond? And they show data that by looking at one of the genes that involves in immune responses, they could predict which patients were going to have high titers and not, so then you can select selectively. So that's an example of one of the treatments, immunotherapies for the treatment of drug addiction. So we have research, clinical cocaine, we have nicotine, we have heroin, we have methamphetamine.